So today I'm going to talk about forensic case formulation, and this is an outgrowth of some of the work I've done over the years on clinical case formulation, especially from a behavior analytic point of view. And the real person that we should thank for this is Mary McMurran, who retired recently from the University of Nottingham. She and I edited a book on this topic, and so really she's the one that taught me most of the stuff related to this. My background is a clinical psychologist in Britain, where I did my training at the University of Liverpool, mostly focused on staff and parent training related to developmental disabilities, mostly in adults. This is where I started. But over the last 20 years, being in a behavior analytic doctoral program, we have lots and lots of people interested in little kids with autism. But little by little, I'm getting dragged back into the world of adult services. And so I've moved backwards and forwards between both research and practice over the years. When I came to the United States, I worked in institutional settings for about 10 years, looking at training master's level therapists to write functional behavior assessments, looking at individuals with severe behavioral and psychiatric disorders, and doing facility-wide initiations for safe reduction of restraint, which we'll talk about this afternoon. So I'm going to skip a couple of slides here and move on to the main topic. So to start with, what is case formulation? So case formulation is something that comes from not just clinical psychology or behavior analysis, but if you look at professional standards for psychiatry, mental health counseling, and other professions, many of those professions will identify case formulation as a key professional competency that everybody should have. So before we jump into that, what is it? One of the best books comes out from a guy called Tracy Eales, an American academic who's edited large handbooks on case formulation for a variety of mental health issues. And his general non-theoretical definition is it's a hypothesis about the causes, precipitants, maintaining influences for a person's psychological, interpersonal, and behavioral problems. So notice that the definition tries to highlight the importance of explaining the development of the problem as well as the current presentation. So a common theme in case formulation is not only what's going on now and what are the variables that influence the problems that we're looking at, but also what's the history and how can you integrate that history into the overall formulation. People come up with different definitions. There's a whole industry of academic books called case formulation for, you name it, depression, anxiety, psychosis, an alternative to diagnosis, something like that. And there are probably tens of books that have come out like that. If you go into Amazon, you'll find 20, 30, 40, 50 books on this topic. So most of the work has come from clinical psychologists, like the guys mentioned here. And here you'll see some of these are more recent and more cognitively oriented. Some of them, like the definition from Kuiken, emphasizes a collaboration aspect to making formulation. It's an activity that not the therapist does to somebody, but they do with the client. And according to Kuiken, it's got these other things that it's supposed to help people be less stressed and build client resilience as well. So these other claims that are made for what could be good about doing a case formulation. So those are some of the different definitions that are there. So a good question is, well, why bother? Why do that? And mostly when people describe clinical case formulation, the pitch is usually as an alternative to diagnosis. And the argument goes something like this, that within a particular diagnostic category, there's a lot of variation that a single diagnosis doesn't account for. So you put people with a diagnosis of depression who are ostensibly all the same, and some people do well at standardized treatment, some people do poorly, and some people do worse because of the treatment. Why is that? Another pragmatic reason is, what if you have people with multiple diagnoses? Someone comes in with a diagnosis of autism and anxiety and obsessive-compulsive disorder. Which of the diagnoses do we pick to drive treatment? It's not clear. So those are some of the cases for making a case formulation. And also some people come along and they just don't fit diagnostic categories. And if you don't have a diagnosis, what you have to drive the selection of treatment. So the rationale behind case formulation is to understand those individual differences to help us select the best treatment for that particular individual and to avoid the treatments that are harmless and ineffective, and avoid the ones that are harmful as well. So the rationale that people like Eels comes up with is a good formulation should predict the effective and ineffective treatments. It should be and make us do something better than we're going to do anyway. If you're going to put somebody into an anxiety management group because they have an anxiety diagnosis, well, why bother doing a case formulation? Well, there's only one real good reason to do that, which is you're going to do better than the standard treatment. So treatments based on formulation should do better than what we're going to do anyway. The goals of case formulation, it should be tight, it should be short, and just abstract out the key features of an individual case is going to direct you to the best treatment, but it also has to be comprehensive as well. Most people looking at case formulations want to make sure that the information about history is reflected in the formulation. And it should direct us into treatments that are going to work, that are going to be evidence-based. So those are some of the reasons for doing it. Now, as I mentioned before, there's this academic industry of all these books on case formulation. You have people like me writing books on behavior analytic approaches. Most people write about case formulation from cognitive behavioral perspective, but there are books on psychoanalysis, psychotherapy, psychiatry, and so on. And some are relatively theory neutral or atheoretical, like general approaches that you can use from any approach. So let's look at some examples of that. But before I go into that, I just want to mention that if you go back and look at Skinner's book, Science and Human Behavior in 1953, he just presents some cases where he presents models about what should be done in mental health that look very much like clinical case formulations, but using behavior analytic ideas. So we'll look at some of that a little bit. So one of the most popular approaches comes from Wira Sakira, called the 5 Ps. And so what she put together are 5 things that should be in a case formulation. So there should be a definition of the problem. You should list the predisposing factors. You should list the immediate triggers for the problem. You should mention the factors that you think are maintaining the problem over time. And you should mention the factors that are protecting the person from problems getting worse or from relapse. Now, if you look at that, these don't mention any ideas from psychology, really. They're just like an acronym using everyday language. So you could use those 5 Ps if you're a psychotherapist, behavior analyst, or a cognitive behavior therapist. So that's the 5 Ps. Anyone can use that from any particular perspective. And many people like it because of that reason. But as I mentioned before, Skinner talked about this quite a bit in Science and Human Behavior. And he has a model of psychopathology and a way to change people's behavior related to problematic behavior. And briefly, his model goes something like this. Society is very good at controlling our behavior, especially related to primary forces. I noticed that when people went to get their free breakfast up there, nobody ate all the cookies. It's very strange that they don't really, because they're delicious. And we might ask ourselves why we didn't do that. Well, we do that because of our history of punishment. Over time, depending on where you're from and what kind of family members or other people raised you, people scowled at you or spanked your hand or told you were greedy when you do those terrible things. And so we learn to inhibit our behavior through a history of various kinds of punishment. Now, you're not supposed to say this in mental health issues. Punishment is great for controlling behavior. It stops people doing a lot of bad things. We don't cross the traffic when we're going to be hit by cars. And so there are various ways. It's very good to respond to positive punishment. It keeps us safe in various ways. But of course, it comes with some problems. Histories of punishment come with histories of teaching people to discriminate when they're going to be punished and when they're going to be punished more. And so you see the kid who reaches for the cookie and looks around and waits for somebody to disappear. Or they'll tell you, did you eat the cookie? Well, not really. I just had some little pieces on the side of the plate, but I didn't really eat the cookie. You know, did you get your progress notes in on time? Yes, but they're not in my mailbox. Well, yes, they're not in your mailbox, but I did do them mostly, you know. And so we learn to lie, minimize, and dissimulate because of our history of punishment. And over time, it has other emotional side effects like anxiety. When we have the predictors, the discriminative stimuli for future punishment, it's not the future punishment that causes us to inhibit our behavior, because it hasn't happened yet, but the stimuli that predict the punishers interfere with our operant behavior. When your boss walks past and scowls at you, what do? Right? We often freeze and stop behaving. Your boss didn't actually punish you or suspend you or say bad things to you, but we know that scowl, what it means from the past. It's a predictor of punishment that interferes with ongoing operant behavior. And sometimes if people have a long history of punishment that's too bad, then they just become passive and don't do very much of anything at all. And so there's all kinds of problems to do with that. So the kinds of emotional byproducts of punishment and the stimuli that predict punishment look like fear and anxiety. There's a Estes and Skinner paper in 1941 looking at how the predictors of punishment cause animals to freeze during operant performance. And then that's used as a screen for anxiolytic medication. If you give your rats a drink of alcohol or anxiolytic medication, they'll keep on behaving. So it's actually used in psychopharmacology to screen for anti-anxiety drugs. And so we see all these other negative effects of society's efforts to control our behavior. Of course, in the end, if you're chronically anxious, chronically fearful, then you're at risk for learning other bad operant practices, like not just avoidance, but having a drink to relax. Not just when you go to the bar to have a beer, but having a drink to relax before you go to work, or before you have to face your family at breakfast, and so on. And so there are many negative effects of punishment histories that look like mental health issues, according to Skinner. So he writes up a little case study, and the example he uses are people with transitions. In the early version, it's a guy that leaves the military, that comes back to civilian life. Here it's somebody graduating from college and has problems because all the things that were important in college that were reinforced now in the new work environment are problematic. They're no longer effective. A lot of his behavior that was reinforced is now under extinction. And so we have these two columns where he says, in everyday language, right, you feel frustrated. What are you doing? You're emitting the operant behavior that used to work in college, and now you've got to do something else, you don't know what it is, and you experience the effects of extinction on your own behavior. And so the emotional effects of extinction we know very well include increased anxiety and aggressive behavior as well. You feel, in everyday language, uneasy and anxious. You're unable to avoid aversive consequences, criticism, and so on. And then you're exposed further to punishment with the elicited side effects from that. You don't know what you're doing, you're unsure of what you're supposed to do, you don't feel you're good at your job anymore. There's low rates of reinforcement because there's not much appropriate behavior to reinforce. You feel guilty. These are side effects of extinction and punishment. So Skinner talks about this way in a way that looks rather like a clinical case formulation. So when I look at this, this is not bad. The books that he wrote were for public consumption, and so they're not very, very analytic. But he gives a good narrative description of everyday cases, which I think if most therapists did it, we'd be pretty happy with that. He does use basic behavioral concepts like histories of reinforcement, extinction, and punishment, and its side effects. And he doesn't, interestingly, spell out what you should do in terms of treatment, but he hints at it in various ways. Skinner, I think, was kind of smart because he never actually said use a token economy and so on, because I think he avoided endorsing specific treatments because what if his guesses were wrong? Maybe he's being smart. But what he did do, which is kind of interesting, is that he said, basically he emphasized the role of behavioral self-management in mental health rather than specific treatments from therapists. We'll come back to that later on, I think. So after Skinner's work in the 50s and 60s, you'll see a number of classic papers in areas of depression, autism, stuttering, all the stuff on token economies, where psychiatric inpatients were developed, and people took off the work of behavior analysis, especially in areas like autism, and to a lesser extent, areas like depression. One thing that's missing, which is a surprise for behavior analysts, are true experimental functional analyses, systematic demonstrations of turning behavior on and off. But there are a handful of them out there, and here's one little example. This is a functional analysis of a phobia, and what you see here is a paper by Jones and Pat Friman analyzing phobic behavior. And this is an individual with insect phobia. And so what they did here in what we call a multi-element design is we have in the analysis part 3 conditions. And we'll have a bunch of sessions here, like brief sessions, 10 or 15 minutes. And here we have the number of math problems that the individual completed. So if you're extremely fearful, right, you can't do your math problems. So this is the measure of fearful behavior. And so you see here, in these sessions, the individual's told there aren't any bugs in the classroom. And you see he does most of his math problems. There are other conditions where you say, there might be some bugs in the classroom, I'm not sure. And then other conditions at the end where you say, there are bugs, the actual physical, they have bugs in the classroom let loose. And so you see the guy's fearful behavior was a function of the environmental conditions. You can turn fearful behavior on and off, just like a functional analysis of self-injury or aggressive behavior. It's really no different. Here we have a number of treatment conditions. So I think this is a exposure treatment. And you see it's not very effective. Only when you combine exposure with reinforcement for completing the math problems do you have low rates of fearful behavior. Then we have a little reversal design here at the end. So, can you do functional analyses of mental health problems? Yes, it is possible to use that method. And so here you have an example of the kind of formulation about what the triggers are for fearful behavior, analyzed with a little individual experiment, and then using that information to drive individual treatments. And interesting to find out that the most obvious treatment is not particularly effective for this individual. I actually had lunch with Pat Friman in October here in Toronto last year. I said, I wish you had a measure directly of the fearful behavior. He said, well, yes. I wish you'd taken the data too, because when the bugs were in the classroom, the guy would stand on his desk, cover his face up with his hoodie, and tremble. So there's a measure of observable fearful behavior. But I guess you can only collect so much data in the real world, in the real resources you have. There are lots of other approaches to behavioral case formulation, and that's one typical approach. Most of the work done in traditional depression, anxiety kinds of problems tend to use behavioral concepts, but don't do experimental functional analyses the way that we saw there. And to some extent, they will accept self-report about behavior rather than observational data as well. So most traditional outpatient mental health services, if somebody says, I got very fearful when I went into the mall, but I felt a lot more relaxed when I stayed at home, most therapists are prepared to accept that as the data to drive the work with the individual. Some people have used multiple methods, self-report, report by others, role play, and so on. And one of the guys that does this kind of work is this guy Haynes, and using what he calls these functional analysis clinical case models. Now you see you have this like little metro map of what's going on. So what is this? So you'll see here these little boxes about what are the main problems that this person presents with. The main problems are headaches, which are relatively intense, 8 out of 10, sleep disturbances, marital distress, again more severe problems, and then other problems, a moderate problem for fatigue and so on. So if these are the target behaviors that you want to address, then we can go back and look at what are the changeable factors that have the biggest impact on these problems. And then when we look at this, we see in these circles here, conflicts over child management appear to predict marital distress and not being able to sleep. And not being able to sleep because of worry predicts the sleep problem and so on. There are other not very strong predictors of the headaches here. These have low weightings, and so we're not doing so well at understanding the headaches. People like Haynes use these models of what predicts the main problems to identify individual treatments. So for this particular person, you might start off with training the couple how to work with their kids more effectively, because you're working early on in the response chain, and that's going to take away the predictors of marital distress and sleep disturbance about worrying about what to do with your kids. And so a model like this for this particular person would direct you to that particular kind of treatment. Now, if you think about it, for somebody presenting with headaches, sleep disturbance, and marital distress, that's a pretty, it's not a very unusual treatment, but it's one that's a little different, and it suggests if this understanding of this person's presenting problems is correct, that this is where you should be starting in that treatment. So that's the main purpose of clinical case formulation, is to design these individual models of understanding what drives a person's clinical problems and to base treatment on that understanding. Now, there's a bunch of stuff out there on generic cognitive behavior therapy. And in this approach, people use interviews with the client. They generally accept self-report. They are both overt behavior and covert behavior. Very rarely do you get any experimental studies like the one of the insect phobia. And they tend to focus a great deal on the way people think and feel as being the main cause of the presenting problems. So this is a non-behavioral model. It's got behavioral elements in it, and some of the procedures are behavioral, but the emphasis is placed on the way that people think and feel drives their overt behavior. And so this has been a very popular model. There's masses of training and professional development in this area. It typically does not mention ideas like stimulus control. It doesn't mention a great deal about contingencies of reinforcement. It may be kind of like mentioned in passing, you know, this is what we did in terms of changing the person's behavior, but it tends to downplay that and focus on changing the way people think and feel as a driver both for understanding the problem and for how you should treat it as well. By changing the way people think and feel, then you change their overt behavior. So we end up with models like this where as you see here, it's the emotion that drives behavior. It's anger and anxiety that causes the person to be selfish and inconsiderate and so on. And thoughts and perceptions are what drive emotions. So that's a different approach to case formulation. But it's one that's probably got the largest amounts of research, the largest number of books and so on relating to that. And perhaps it reflects that most of this work is done without patients with anxiety and depression, without developmental disabilities. There is, of course, a large literature now by people in Britain like Beazer, Stenford, Cruiser on adapting cognitive behavior therapy for individuals with mild and moderate intellectual disabilities as well. And there are forensic applications in the work on anger management as well to do with individuals with mild and moderate intellectual disabilities. Now, you might think sometimes that these case formulations are really best suited for discrete problems like phobias or simple depression after a loss or something like that. But in fact, that's not the case. If you go back and look at an old book on behavioral case formulation from 1985, you'll see that in fact people have attempted to use case formulation for more complex problems. And if you think about personality disorders, that sounds like something that's particularly diffuse and pervasive and kind of hard to tie down. And yet, the early work on behavioral case formulation went right into this issue. And if you look at this book, there are at least 3 examples of case formulations for individuals with personality disorders. And so how do you do this for something that's so diffuse? Well, basically, you try and break down the presenting problems into a number of specific groups of problems. So the discrete target behaviors might include things like avoidance of criticism and evaluation. So what is that? What do people do? You see examples of that there. There are physiological problems to do with avoidance. There are the way that people think as well, covert behavior. And some of these incidents may be relatively specific, that these particular aspects or target behaviors of a personality disorder tend to occur in certain situations. Sounds familiar to people like me, right? So when supervisors do things, when there are exams, when you have to speak publicly, those can be specific environmental triggers that drive the particular target behaviors related to a personality disorder. So it's possible to break down even something as diffuse as this into specific aspects of behavior. So in one of the chapters, Sutker and King do a functional assessment, if you like, a case formulation of antisocial personality disorder for a young adult referred to his physician because of back pain following an accident, and where there's no obvious causes of a back injury. And so the referring physician assumes that some kind of functional overlay going on. And so at this point, the therapists don't know anything about personality disorders or exactly what's going on. And using interviews with him and his wife, at first the guy seems pretty fluent verbally. He seems emotionally responsive. He talks a lot. Little avoidant about the future and the marriage and exactly what's going on with his back. So there's some issues there that he's avoiding discussing at least. And he will mention minor problems as an adolescent, but it's all very minimized in terms of what he talks about. And did agree to do 2 weeks of self-monitoring and give a fairly clear history for someone who's pretty smart, someone who seems quite depressed, scoring high on psychometric measures of psychopathy, a rather impulsive individual who's really relatively bored, and his wife reports that when he's in structured environments, these problems are minimized. So he's an ex-military guy as well. So even here, you see the beginnings of functional assessment in terms of like structured, unstructured environments and so on. And you can see some of the potential reinforcers in terms of avoidance of certain issues, minimizing his problems and so on. So even just from the basic first couple of interviews, you can see the kinds of picture that you can develop. So as in the previous slides, we can break down this antisocial personality, this set of problems, into 4 main kinds of problems. Problematic use of alcohol and drugs and sexual promiscuity, kind of using other people for his own ends, problems about not being able to manage negative mood, things that he complains about but he doesn't know how to handle correctly, problems with impulsivity and delay of gratification, and just being socially immature with his family members as well. So that's a way to start breaking down a broad problem into a bunch of specific problems, which are relatively easier to deal with. In this chapter, the authors do look at a developmental analysis of his problems. And so some things that they look at, it was a lack of rules as a child from his parents, modeling for domestic violence and drinking from his father, and models of promiscuity, mother who does have rules but doesn't enforce them. And so the guy doesn't learn the self-control that we talked about earlier on. He learns to steal the cookies with impunity throughout life. And peers who reinforce and model these kinds of antisocial behaviors. Because he's not good at waiting for reinforcers, he gets bored easily, and so he doesn't know how to entertain himself with positive reinforcers. Then he becomes impulsive and accesses problematic thrill-seeking kinds of reinforcers that was led to a combination of criminal behavior and drug use. Again, we go back to Skinner, right? We have problematic drug use to reduce aversive internal stimulation. And then he's just not clear about what his life is about. He doesn't have any life goals. He's just concerned about the immediate presence and so on. And he's married an unsophisticated wife that he can manipulate. He's got a history when he was in the Marines of excessive sexual behavior and drugs and so on. And it's only when he starts to get in big trouble for losing jobs, DUIs, marriage breaking down, and so on. At the same time supported by a rescue wife who's going to fix it all for him sometime soon, where you see that it's that recent set of problems that precipitated the referral. So that's kind of a developmental analysis that's consonant with the presentation. So when we look at this set of problems, he has this cycles of behavior to do with negative mood, lack of activity, which are typically solved by these acting out behaviors that eventually get him into problem and contact with the law. And he lacks the skills, he lacks the behavioral self-management skills on how to fix those problems for himself. So, when they look at this case, they boil it down to focusing on three things: cutting down on alcohol, cutting down on drug use, management of depressed thoughts and behavior. So you can take that big mess of problems and kind of like the previous diagram of case formulations, there are just three things to focus on for this individual based on the formulation. They were able to work with him to get specific broader treatment goals. And so he would eventually agree that he would like a life that's free of substance abuse. He's somebody who's pretty bored, so he's going to have some kind of excitement. It just has to be something other than drugs and promiscuity. He has to be able to manage his own anxiety and depression. He needs to have a life that's more regulated and interesting to him. Either he has to get a better marriage or he has to separate the best way they can. You've got a very smart guy who's underperforming that could be a professional or complete education and so on. But you can take that kind of formulation for personality disorders with, I mean, imagine a fairly messy case. But in the end, you've got three treatment targets and some long-term targets to work with that individual. So that's how people have used this. Over the last 15 years, people have emphasized that case formulation should be done with the client, rather than the expert sitting behind the desk, analyzing the person and telling them what to do. People have suggested that it's better to do this collaboratively. So one of the great contributions from Mary McMurran is this little summary cards here. So yeah, how would it be if I tell you all about yourself and you should take good notes on this because it would be good for you, right? So that's one of the rationales for involving clients in understanding their own problems and maybe being able to generate some of their own solutions as well. Everything I see parallels with behavior analysis. And so the cute cartoon really is foreshadowed by what Skinner said about mental health work. And one of the things that Skinner said is that when a therapist is working with somebody, it's very tempting to tell somebody, well, what you should do with your life is this, 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 and this. Now go and do it, and then come back and see if I'm right. So Skinner says it's a bad idea for a couple of reasons. The first obvious reason is people say, no, I'm not going to try that. That's stupid, So that's one reason not to do it. But there's a more clever reason for doing this. And so Skinner does kind of make one relatively specific suggestion, which is to get people to self-record their own behavior and its relationship to the environment. And there's a couple of reasons for doing that. There's a more obvious one, which is looking for variations in their own behavior and the relationship to the environment. But the clever reason is that when you ask people to do that, you're already changing their behavior. And so later on when you meet with them the next week or a couple of weeks later, you've already influenced what they're doing. They're writing things down. They're starting to change the way they talk about themselves. You know, I noticed when I saw the animals in the pet store, I was kind of not happy when I was doing that. But when I stayed at home at the weekend because my sister cancelled going to the movie with me, I felt really miserable. That's kind of funny, isn't it? I thought I was just depressed. But I'm not depressed in the pet store. I'm a lot more depressed at home. Now, sometimes people will then take the leap. You know, the weekends, go to the pet store, or something like that, right? So Skinner makes that point, that by getting people to self-record, you've changed their behavior, and if you're lucky, they start to discriminate the relationship between the environment and their own problems. And maybe they will make the connection between what they could do in terms of managing their own lives independently. Okay, so there are some pluses and minuses to co-production. It's good to involve the person. You might get the information that you otherwise might not get. Maybe you get a more respectful alliance with the person. On the other hand, you're dependent on the person. They may not tell you everything. They might not tell you the truth. You might have to challenge their account of the problems that they give, and it might take you more time as well. So there are pluses and minuses. There's very little research on co-production so far, and what there is actually mixed. Some people like the co-production. They think it's helpful and gives them insight. And other people say, you know, when I realize what's going on and my problems trace back to when I was 8 years old, I'm 50 years old now, suddenly my problem seems overwhelming. So the outcomes are not well researched. And this is more like service ideology, more so than science. So I think I'm going to jump around a little bit. I want to finish on time. So remember, the reason for doing this is to make sure that we get the best treatment for the person. So there are already some pretty good treatments out there. The efficacy of cognitive behavior therapy for depression and anxiety, pretty robust. That's probably a good place to start for many problems that you would see in adults. So if you're going to do case formulation, you should be doing better than that, right? You should be doing better than treatment as usual. If you're going to take a new painkiller, it should be better than aspirin, right? It's not better than placebo that's a relevant standard, right? So when you think about how would you show that case formulation works or leads to better outcomes, it's a little trickier than you might think. So first of all, you've got to show it's better than treatment as usual. You've got to make sure that the case formulation is done competently and correctly. You've got to make sure that the therapist translated the formulation to the treatment correctly, which is a separate issue. Some people can do it well, some people don't. The most effective treatment should be the one that matches the case formulation, and the treatments that don't match the formulation should be ineffective or worse. So those are the things that we should be able to show, right? So what do we know about the effectiveness of case formulation? Some 10 years ago, persons working with people with anxiety and depression looked at case formulation-based treatment for 58 individuals with anxiety and depression, and it could be done in private practice context. Most of the people had some kind of adjunct therapies like psychopharmacology, but generally speaking, people did better, and the outcomes were somewhat similar to group cognitive behavior therapy. So that's okay to know, right? But when you look at this, it doesn't really pass the key tests, right? There's no control group. There's no group that gets group cognitive behavior therapy. So it lacks the key tests for the efficacy of case formulation. A very interesting paper was done on anxiety disorders back in 1992, and I really like this paper because it does pass some of the key tests. So this is done in Germany, where they randomized 120 individuals with anxiety disorders and this is the clever part. So a third of them got individual case formulation-based treatment. So I'm agoraphobic, but I fear screaming in public when people stare at me. So I'm going to exposure to people staring at me. Someone else with agoraphobia might fear being trapped on the bus, in the elevators, and so on. So I'm going to get exposure to those things. So those are individually based case formulation treatments. The control group, number one, just got exposure therapy. Just standardized 1970s exposure therapy for anxiety. The interesting group are the yoked control group because they got individualized treatment, but they got other people's individualized treatment. So this is the key test. So if I've got an anxiety disorder, but I get his treatment and it doesn't match my formulation, then it shouldn't work. So bad news for case formulation, at least in this study, which is what worked across the board was exposure therapy. Both in the group that got exposure therapy and in the group that got individualized treatments that matched and where the treatment involved exposure, and even in the yolk control group that got exposure therapy for other people's problems, they too did pretty well. So, no good news for case formulation in this study. But maybe because, if you go back, right, to the 1970s, exposure therapy is highly effective for anxiety disorders. So maybe doing better than that might be hard. So, it seems here that the flexibility that as professionals we like and think is important to us might not be a good thing. So that's the bad news. Here's the good news. Atte Garderi, who works in Scandinavia, did a randomized control trial for bulimia. And again, we've got pretty good evidence-based practices for bulimia. Again, various packages of cognitive behavior therapy seem very effective. So it's a relatively tough case, but he randomized 50 individuals with bulimia to either the manualized treatment or broader treatment that was based on a functional assessment with individualized treatments based on those functional assessments. So both treatments worked pretty well compared to baseline, but there was a difference in favor of the individualized treatments. So here's an example of the good news, where even when you have a fairly effective package of cognitive behavior therapy for a bulimia, individualization actually has pretty impressive improvements. So for example, most of the non-responders were in the manualized based treatment. So it seems like the individualization picks up these people and can give them treatments that work. So that I think is some of the most impressive, that they're taking off the bottom of the people who don't respond to the standard treatment. So where the standard treatment doesn't match the person's problems, individualization can improve upon that. Recently, there's an individualized treatment comparison for depression. Again, it's a bit like the Garderi study, which is you have pretty robust treatments for depression already, and we have 121 individuals with acute depression and additional problems. They're taking online modules for cognitive behavior therapy that have been shown to work, but the individualized group get individualized plans based on individual information and self-report. And generally speaking, individualized treatments worked better than the standard treatments, and that was especially true, it's interesting, especially true for the case of severe depression. Sometimes you'll see in the literature people expressing opinion that cognitive behavioral treatments are really for the mild cases, and for the severe cases you need psychopharmacology, but maybe that's not true, because in this example here, it's the people with the most severe depressions that respond more to individualization. The outcome literature is mixed, because in the comparisons where you're against a standard treatment, you may have ceiling effects that mean it's kind of hard to improve on what's already relatively effective and so on. And you get issues to do with how well were the formulations done and so on. So for example, in the Barkham anxiety study, the therapists were graduate students with at least 1 year of experience. So the details of the training were not really given. Maybe they just weren't very good at doing formulations. Maybe if they got better training and more experience, maybe they'd do better. So there's always that argument in the back of this. Now, people have applied case formulation to forensic populations as well. I noticed at the beginning of the presentation, I've got this book out now from like 2011 to do with case formulation of forensic problems. Now, if you can do this with relatively straightforward anxiety and depression, or for discrete problem behaviors for individuals with disabilities, can you do it for individuals with forensic populations? The answer is yes. There are models out there that we can all use, but there's an immediate list of problems. First of all, when you are trying to work with individuals with forensic histories, typically they have very long histories. There's a vast amount of information. It isn't like you're working with someone with a discrete depression that started 18 months ago when the kids left home. It's not that. Often you've got all this data which may be accurate, it may not be accurate. People why. This includes the patient, their family members, the therapists, the staff that work with them. Some stuff just may not be available to you. So the issues of accuracy and completeness of information are much more prominent when it comes to do forensic case formulations. But as I mentioned, there are at least 3 and maybe a 4th set of methods that you can use specifically as models for forensic case formulation. I'm going to discuss these in some detail in a little bit. One is by my colleagues, Michael Daffern and Kevin Howells. I work with Kevin Howells. Probably he stole some of the ideas from me over coffee at Birmingham University in about 1985, I think. But it's good of him. He stole the right stuff. Then we have similar ideas to do with integrating ABC analysis with history. And then we've got some models from the Netherlands from Paul Emmelkamp and colleagues. So here are a bunch of things that people can do. So Michael Daffern and Kevin Howells were working in Australia in inpatient units for psychiatric patients, some of whom had forensic histories. And so they focused on the immediate antecedents and consequences. And what they were doing is basically taking incident data or some observational data and trying to figure out why did the incident of aggressive behavior occur. Well, obviously some of them occur when staff ask someone to do something they don't want to do, and then the staff push them too much. Sometimes the person becomes aggressive to make somebody else do things for them that they want them to do. Sometimes people appear to be reactive and angry in the situation. Some people report that after they're aggressive, they're kind of chilled out and more relaxed. Maybe it's preceded by a period of time where they're getting progressively more and more anxious and tense. Some people are aggressive to get stuff, right? Acquisitive offenses, to get money and objects. Some people appear to be aggressive because they want attention from staff or peers. Some people get social approval through their aggression. Some people are aggressive through the instructions, and some people seem to actually be reinforced by observing people suffering. And when I read that recently, maybe I think of one of my colleagues that I work with. So we all have perverse forms of condition reinforcers. So, so they took data on 502 incidents of aggression, and unsurprisingly, the most common trigger was anger in this particular population. Demand avoidance happened with staff, not with patients. When you think about it, no surprise, right? And then access to tangibles was rarely a function. So this information is pretty kind of down-home, simple stuff, but it tells you something very important for your program, which is you better have effective anger management programs in there that people go to and actually learn the stuff. We're good to train your staff, because they do have to ask people to do things. People do have to have showers or go to appointments or move around the unit or give up their food when mealtime's over. But there's a good way to do it and there's a bad way to do it. And so if you have this kind of data from where you work, at least do those 2 things, right? Don't waste your time talking about tangibles to your staff. Do spend time getting your anger management program in really good shape, pick up the non-responders, give them extra training and so on, and do a lot of staff training related to giving instructions. So that's an example of the kind of work. In a follow-up study, they added 2 additional functions that they call sensation seeking and sexual and sadistic gratification. So I think this is nice. But as I put this together, I thought, well, let's get scientific about this. And the words and the ideas that you have in those papers are, in a sense, they're not really psychological words, right? They're everyday concepts that we all have. If you ask my mom about why people are aggressive, my mom could have given you most of those answers. They're not really behavioral science-based ideas, but here are the ones that I like, of course, which is we've got two kinds of aggression, operant and elicited aggression, and we can take those ideas. Most of the negatively socially reinforced behavior is to do with demands, right? The aggressive behavior is reinforced by removal of the staff or removal of the task. A lot of positive social reinforcement, attention, enhanced status, people doing things you want them to do, getting people to do things for you, observing different kinds of suffering from different people. Some people, not so many, but some, seem to get a buzz out of the behavior itself. The rush of being aggressive is reported to be important. And other people have negative, non-social negative reinforcement. So it's a pathological, inappropriate way to relax, right? And at the end, we have good old Azarin's elicited aggressive behavior, that if somebody hurts you physically or metaphorically, right, it elicits aggression from people. So we can take that information, and much like in the functional analysis literature elsewhere, all these different classes of functions suggest different kinds of treatment. If we take, we saw it already in the case formulation for the individual who's bored and under-aroused, instead of taking drugs and stealing cars, maybe you can go, have a hobby of jumping off in parachutes or something. But there are appropriate safe forms of sensation seeking that could match the function for that individual. For some of these social reinforcement, we have a whole technology to do with changing the contingencies of attention, teaching appropriate forms of social behavior, non-contingent reinforcement to make sure people do get talked to some of the time wherever they are. So this maps more clearly onto treatments, and it uses ideas from behavior analysis, which of course I like, right? So, second approach addresses a problem which is kind of quite interesting, which is, Skinner calls this the problem of the first behavior. When a kid says their first word, why did they say it? It can't be because it was reinforced in the past, because it was their first word, right? Where does it come from? There are lots of examples of that, right? Think about this in terms of forensic issues. When somebody breaks into an elderly couple's apartment, ties them up, tortures them, and murders them, and this happens the first time when the individual's 35 years old, how did that come about? It seems inexplicable. And mostly, if you ask the general public, they will tell you those kinds of things. There are bad people out there. They just go crazy. They just, who knows what happens, but there are bad people who do these things for no reason at all, or no reason they can understand. But people have developed modifications for analyzing the history to try and explain this. So people use the ideas of antecedents, behaviors, and consequences to organize the clinical material based across the whole development. And they use these kind of like little graphics that, what do you learn when you're 3 and 4 years old? What do you learn as a teenager? What do you learn as an adult? And then maybe when this inexplicable thing happens that gets the person into first contact with forensic services, maybe if you know the rest of this story, it might make sense. So how do people learn to do these awful things? So here's an example. Hart and Clive Holland, people like that, have worked on this. And they use this example to organize the history and to try to explain how the final incident with the police came around. So in this example, they have got this individual, Bob, and in early childhood, he has poor parents, he's sexually abused by a stepfather. There's more close antecedents where he's criticized by teachers and bullied by peers. And so he learns as a child to avoid people a lot. He has these covert behaviors about, he both loves his stepfather, but someone who's done these awful things to him as well. He has ambivalent feelings about his own sexual orientation, and he starts to acquire violent fantasies and social anxiety. And so, the key consequences, right, appropriate forms of social interaction are punished early on, and they become socially isolated. So in these guys, they then summarize this in what they call the key learning. So he's learned that other people are not going to respect him or give him the time of day. Men are threats, and he's somebody who really doesn't deserve friends. There are lots of little kids like this, right? That by itself is common and unremarkable. So in secondary school, there are incidents where he's not getting peer approval and he's hanging out with the wrong crowd who asks him to steal a car. So he skips school, steals his car, but then his so-called buddies abandon him, and he's a patsy who's left when the police come to find out what's going on, and then his friends make fun of him even further. He gets more and more isolated. He learns he can't trust people and that he's viewed as a worthless person. Again, not that uncommon, right? But you can see how this case is going, right? If other bad things happen to the guy. So I'm skipping some steps here, but in the key incident, he is in a bar with some buddies where one of the guys he's with is somebody he doesn't particularly know but is gay. Everyone's getting drunk. The others kind of invite everybody back to the guy's flat. They all drink all his alcohol, right? More disrespect, and pretty much just leave him alone, but he's hidden a knife just in case he might need it for something. And then you've got these overt behaviors being more withdrawn from the group, and the thoughts that he's been under threat from this guy who's gay. And then finally, at the end, he's left alone with the guy. And in the last part, when the other people leave, he's passed out. The guy touches him. He smells the alcohol in the breath, which is reminiscent of the abuse incidents of him as a child. Then he gets extremely fearful, and he reports, he blanks out, and he murders the guy. So this doesn't make any sense, really. Why would anybody behave in this way? But using this multiple sequential functional analysis, when you put all the ABCs together, it kind of does make some sense. It's one of the things where each little step from step 1 to step 2 is innocuous. And step 2 to 3 and step 6 to 7 are all pretty innocuous. But when you go from 1 to 7, it seems quite inexplicable. But in fact, it does it's a way to make sense of the history and perhaps could have some utility in terms of treatment, design, and so on. Okay, third approach to doing forensic case formulation comes from Vedel and Emmelkamp. Emmelkamp works in Amsterdam, is a very productive researcher, and doesn't mind taking on some pretty tough issues. And so they did a chapter on working with individuals with chronic multiple substance abuse, people who are court referred who don't particularly want to see therapists, and individuals who are angry and got legal problems and feel coerced to come along. And they've got two things that they use, which is, I think, is quite interesting. One is they give them a balance sheet. What are the pros and cons of continuing to drink and not drinking? And then they basically have an extended ABC analysis of the problems. And these methods are useful because they point you in the direction for where treatment might begin, and they point you in the direction for some of the behavioral self-management strategies that individuals might engage in. So here's an example for one individual they present. Why use alcohol? I can give you lots of good reasons. And I certainly go for the first one, right? It does help you relax. It gets rid of your social inhibitions. You get chatty and you have a good time sometimes. The advantage of change, your probation officer is going to leave you alone. You're going to save some money. So there's some good reasons to cut down on alcohol use. Disadvantages of using, well, you're going to get into trouble and you're going to have hangovers. Disadvantage of change, I think this is the part I like because it tells you about the case formulation-based intervention. So if you're not able to drink, you can't relax, you can't blow off steam, life's going to become boring. This is really, really useful because it tells you how to do the individual treatment, which is this guy needs a different way to blow off steam. He needs a more interesting life that doesn't revolve around alcohol and substance abuse. So how can the therapist address these problems that are identified in this little balance sheet for substance use? And they also do another one for cocaine use as well. In addition, they have a series of basically modified ABC charts. What are the external cues for alcohol use? Being on his own, very common one. People in authority hassling you about stuff. And imagine that if you had a bad day, you've been waiting for services, people are nasty with you, and you go home and there's nothing to do, and you're bored, what are you going to do? I think this one answer is pretty easy. They include internal covert behaviors. People are picking on him. He feels angry. He has tense muscles. Again, very clear cues that you could teach the guy to respond to. That when you feel like this, right? We all feel like this sometimes, right? When you feel like this, what do? There's something else you can go do that gets you relaxed and so on. There are specific antecedents to do with cravings, dry throat, saying he needs a drink now, being restless. In this example, he drinks a large quantity of alcohol, and in the short term, he feels pretty good. He feels relaxed. He can face his awful probation officer, but he also has cravings for cocaine and feels out of control. He's got these long-term distal health problems. Again, this is interesting, the overlap between psychopathology and everyday life. I have a colleague who could not give up smoking. And no matter how she tried, no matter how she self-recorded, she just couldn't do it. And then she figured out, kind of like this, that, you know, she tended to smoke when she had a few drinks. So it was a great way to remove the antecedent for smoking, which is to stop drinking. She actually did it. She stopped drinking for 2 years, and then it's kind of hard, right? Maybe not the program for you, I don't know. But she gave up, she really wanted to give up smoking. So that's her, not you, okay. And that's what she did. She gave up drinking, didn't smoke, and then gradually faded the alcohol back in. So there's your behavioral self-control. Give up your immediate positive reinforcer that has long-term health issues, and then fade back in the one that has, has other problems. Okay. So there's an example of case formulation related to substance abuse. So there's the 3 kinds of technologies that you can use to formulate clinical cases. I'll briefly just mention, I didn't cover offense paralleling behavior. There's literature out there on offense paralleling behavior, which is rather similar to some of these ideas. So the last thing I'm going to cover today is some research I've been reading the last couple of months. It's going to be in a book chapter that I wrote with Mary McMurran, which is, if this is so important, how can we train people to do this? And people in Britain have been working on this for about the last 5 years. And so a good thing to find out, first of all, if you wanted to formulate forensic cases, well, what should you formulate? And so they did one of these so-called Delphi surveys. They asked 31 experts with backgrounds in forensic work, psychiatry, and psychology, asking them what do you think should go into a forensic case formulation, what's important, what can be left out. And so everyone pretty much agreed, a good history, including offending history, history of behavioral problems, early trauma, personality, comprehensive accounts of substance abuse, problem behaviors, premeditated versus impulsive, aggressive behavior as an important distinction, and what the person does on the positive side for their lives. Includes issues to do with mental health and so on, these other problems. And they recommended using the 5 Ps from Weir Sakira, I think probably because it's acceptable to most people, irrespective of their theoretical orientation. And something about making sure you have good rapport with the person, and therapists should be aware of the match between their own relationship style and the client. So if that's what goes into a case formulation, how can you measure if a case formulation is correct or incomplete or wrong? It's actually kind of a more subtle thing. But McMurran and others have put together a checklist using a rating scale. So how coherent is a formulation? Does it bring together all aspects of the person's current life and their current environment? And does it bring together their history as well? So coherence is something that people look for. If you just list all the events in the person's life and all the things that went wrong, you really haven't done a formulation because you haven't integrated all the information. But you could take a lot of information and sometimes boil it down to a very few things that are the key. So this is one thing that people often struggle with, both mental health professionals and others, that abstracting out the key things of a particular case is quite important. Even behavior analysts struggle with this. I'm working with a relatively new behavior analyst working on cases of aggression, interestingly enough, with a teenager. And when I first got into work with her, I say, well, how is this individual doing? Oh, it's terrible, she says. Blah, 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 blah. And 20 minutes later, I'm still listening to this long list of complaints about all the things that happen or might happen or will happen. And really, when it comes down to it, all we need to know is there's a function, there's 3 parts to the plan, we've got 2 parts done, we've got problems with the 3rd part. We're going to work on the 3rd part of the plan. That's all we need to know. And so an important part of case formulations is to be able to do that. Here it's called coherence, but just to abstract out a few features that are important that drive treatment. So that's an important aspect of a good case formulation. Make sure that the explanation includes presenting problems and history. Interestingly, simplicity, just like the example I just gave. You know, keep it simple and use that to drive the treatment. Be able to make predictions about what will happen. If these things will happen in the future, then it's more likely to cause relapse. If these things happen in the future, it's probably more likely to be good for the individual. And then also have action-oriented treatment recommendations as well. So there's a little bit of work done on this. So most people will agree on the key features of a case if it's given to them in a written form. If you ask people to use this checklist and you look at cases written by experts versus cases written by novices, the experts get higher scores than the novices. So the checklist has got some validity there as well. And we'll see later on that if you compare people's formulations before and after training, the scores go up. So there's some evidence of reliability and validity to measures like this one. In one of the training studies, they took 18 probation officers and they gave them 5 days of training on forensic case formulations for offenders with personality disorders. And they gave them case formulations and they looked at what they wrote for formulations before and after the training, and then they used experts using the checklist we just described. So there's some good news and some bad news. So generally speaking, the post-training formulations were better than the pre-training formulations. There had be if you're going to corral staff into a workshop for a week, right? You should have some impact on what they write. And what they were good at is they improved on getting the facts right, broadening their explanations, more coherence, getting better quality overall. But something that they did not learn was improvement in prioritizing, planning, treatment. So they tended to, at the end, write all these lists of recommendations of the things that really should happen. But they didn't take the information from the case formulation and said, for example, this person has a lot of anxiety around authority figures that remind him of certain family members. Therefore, we're going to teach him relaxation training and assertiveness to do with certain authority figures. That's it, folks, right? So that's the part that's hard for people to do. Or it's hard for these people to train. Maybe we should blame the trainers, not the probation officers, right? So there's some evidence of effects here. So if you ask the raters who are blind as to whether or not the formulations were before or after, they could get it right 8 out of 10 times. So something changed, but I think not enough changed. So at least the probation officers began to discriminate what was going on with the cases, but obviously they need further training about what to do with that information to translate it into individually based treatment plans. So they tend to produce these lists of problems. They didn't link the problems to the functional assessment, and they tended to be weak on identifying the positive behaviors that they should encourage to compete with the problem behaviors as well. So again, those are relatively common problems that all of us have had over time. Last study I'm going to look at has less optimistic results. So they looked at training probation officers again, looking at 2 hours of training. So this is rather less training, right? Only 8 hours, not 40 hours of training. And they looked at these individuals over a 6-month period of time, working with their particular clients that they were assigned. And they didn't find any improvement in case formulation over the period of time. So 20 didn't improve, 13 did. So I think here you've just got not enough training. For me, it's interesting. Someone's very interested in training staff and parents to do the applied behavior analysis. When you look at training these skills, what would you do to get this right? I think I know what I would do if I had the time and energy, right? I think the problem with this is that these are trainings that are put together by people in their ivory towers who are used to talking to people and writing to people a lot. And if you're working with students, they often learn something in that way. But if you want to learn something very specific, like the contents of the case formulation and how to translate that into indicated and contraindicated treatment, I think those methods are not the right way to go. I mentioned before, sometimes people just don't get enough practice. We don't also know what happened in the training. So this is a common complaint that I have in a lot of staff training things. What did the probation officers do in these trainings? I don't know. And neither do the authors of the article. They might have some PowerPoint slides or a manual, but what did the probation officers do? Were they asleep at the back? Were they on their phone? How many sessions did they attend? And if they did attend, what did they do? In a more behavioral approach to training, people would have to complete each of the components of the training to certain levels of mastery and then show the skills on novel, untrained cases, and then they can move on to the next steps of the training. In addition, you might design the training cases using methods like multiple exemplar training or general case training, where you choose lots of different examples of cases that sample different situations that the person should be able to respond to. So you're trying to program the way that people write and think when they're doing formulations. But those ideas are not really out there in the land of cognitive behavior therapy. So these kinds of people don't know much about that aspect. So in terms of training people to do forensic case formulations, we've got a bit of progress. I mean, we do know how to measure it now a little bit. We do know that we can improve people's performance somewhat, sometimes. But in terms of having like a robust way to train people to do this, I don't think we're there yet. I think the problems lie in the design of the training, not the individuals who participate. So that's something we could probably improve in the future. So to wrap up today, just remind you, right, so case formulation is an individual-based approach, often contrasted with diagnosis. We try to integrate the history of the presenting problem into a brief, concise, abstracted summary of the case to predict the best treatment and to predict the treatments we should avoid. There's some evidence that sometimes that case formulation improves outcomes, but it may depend on the context in which those studies are done. We know that we can apply case formulation to forensic cases. There's a bunch of models out there that we can use, and that could be an effective way to train yourself or to train each other to do that. But in terms of training people to do a better job on forensic case formulation, I don't think we're quite there yet. So since we're nearly ready for coffee, thank you everybody. Thanks.